Hi everyone. Today we're going to discuss the most deadly cancer at this time, which is lung cancer. Again, today we start out with a few facts and figures from the American Cancer Society. Lung cancer is the second most commonly diagnosed cancer in both men and women in the United States, not counting skin cancer, which is not reportable. For the last 10 years, the lung cancer incidence rate has decreased an average of 2.1% each year. However, the outcome stats are still very poor. Lung cancer is the leading cause of cancer death in both men and women, which amounts to 25% of all cancer deaths are due to lung cancer. 57% of people diagnosed with lung cancer are diagnosed with distant metastatic disease at the time of their original diagnosis. 5-year relative survival rate for non-small cell lung cancer is 23%. 5-year relative survival rate for small cell lung cancer is only 7%. You can see that small cell lung cancer is obviously more deadly of the two lung cancers. However, both do not have good 5-year relative survival rate. Let's review the anatomy of the lung for a moment. The lungs are a pair of cone-shaped organs in the chest, as you know, that let you breathe. The right lung is slightly larger and has 3 lobes. The left has 2 lobes, with the heart occupying the space that would otherwise be occupied by that 3rd lobe. Note how high the lower lobe goes up in both lungs and how far down the upper lobe goes in the left lobe, or the left lung, sorry. Even though it is the upper lobe, the bottom of the upper lobe actually ends at the same point as the bottom of the lower lobe. When you begin to abstract lung cases, it will help tremendously if you have this or another illustration next to you for a reference, okay? Because, you know, when the radiologist says upper lobe, you just think, you know, upper part of the lung. And in the left lung, that might be way near the bottom of the lung. So having an illustration in front of you helps as a reminder of that. These illustrations that I've been using throughout my presentations were included in the AJCC 7th edition manual on a CD-ROM. In the 8th edition, these illustrations were included right in the manual itself. So these illustrations you should all have within your 8th edition staging manual when you get them next year or next semester. One thing that makes staging lung cancer so difficult is that there are so many different regional lymph nodes. This illustration identifies the different lymph nodes and where they are within the chest cavity. At this time, you don't need to know or memorize the lymph nodes, but just be aware that, you know, there are multiple different lymph nodes. These are their names and where they're located, and that having resources and illustrations in front of you when you're abstracting is very important. Some risk factors for lung cancer are obvious, but they do include current or history of tobacco use in the form of cigarettes, pipes, and cigars, exposure to cancer-causing substances in secondhand smoking, occupational exposure to asbestos, arsenic, chromium, nickel, and other agents, radiation exposure from radiation therapy to the breast or chest, radon exposure in the home or workplace, medical imaging such as CT scans, and then of course you have your atomic bomb radiation. Living in an area with air pollution can also be a risk factor, and family history of lung cancer and HIV infection are also risks of lung cancer. Many people with lung cancer may experience some of the signs and symptoms listed here. However, there are times that people with lung cancer do not have any of these signs and symptoms or changes. Or if they do, they just ignore them, unfortunately. Sometimes people that are not having any symptoms may have their lung cancer identified incidentally on a chest x-ray or CT scan performed for other reasons, such as checking for heart disease. So that's always a plus when it's incidentally found, because it's obviously found at an earlier staging then. Lung cancer can spread and metastasize anywhere in the body, but it is most commonly spreads to the lymph nodes, other parts of that same lung or the other lung, bones, brain, liver, and the adrenal glands. Imaging tests for lung cancer will definitely include a CT scan. A CT will be used to measure the size of the tumor, determine the extension of the tumor, if there is more than one tumor, and if lymph nodes are suspicious for cancer involvement. Sometimes it is difficult to tell if the regional lymph nodes are involved by cancer using a CT scan. Sometimes the lymph nodes, they just look enlarged, but the radiologist will be unable to determine if they are involved or not by cancer. So a PET scan will be performed. Most of the time, a PET scan is more definitive in this way than the CT. The difference between a CT and a PET is that a small amount of radioactive sugar substance is injected into the patient. This sugar substance is taken up by cells that use the most energy. Because cancer tends to use energy actively, it absorbs more of the radioactive substance. The images from the PET scan identify if there is any uptake, and this is considered positive for cancer if the uptake is more than the normal level should be. Okay, so you have your CT scan and your PET scan, and more and more facilities are actually, they can do a CT PET. So it's basically one time that the patient goes and they can do both of them at the same time. So, but a lot of times if it's the initial CT, it will just be the CT itself. The MRI scanning does not work well on body parts that move. And obviously the lungs continuously move due to breathing. So the MRI is not used to scan the lungs. However, it is used to scan the brain. Small cell lung cancer very often metastasizes to the brain early on. So a brain MRI may be performed for staging purposes of small cell lung cancer. Bone scans are used to determine if there is bone metastases. If the patient has a history of bone pain or certain lab tests are abnormal, a bone scan may be performed. However, since a PET is most often used when a patient is diagnosed with lung cancer, it would take the place of a bone scan since it can easily identify bone metastases as well. Diagnostic tests for lung cancer would of course include the biopsy. Once again, the only way to truly prove a patient has cancer would be to perform a biopsy. There are many ways in which a lung biopsy can be performed. It just depends on where the lung mass is, how that mass can be assessed, and what different diagnostic tests will be performed. So a bronchoscopy is almost always performed. The pulmonologist needs to inspect the lung breathing passages. This will determine if the tumor is within the main bronchi or the upper, middle, or lower lung bronchi. Sometimes the lung tumor can obstruct a bronchus. During the bronchoscopy, a biopsy of the lung tumor will be taken if the physician can reach it, and if the tumor is in the main bronchi or one of the other bronchi, it's easily biopsied. A thoracentesis is when they numb the skin of the chest and a needle is inserted through the chest wall and into the space between the lung and the wall of the chest where fluid collects. The fluid is removed and then checked by the pathologist to determine if it contains cancer cells. This procedure is performed if a patient has a pleural effusion. A thoracoscopy is when the surgeon inserts a special instrument with a camera on it to assist in the examination of the inside of the chest. This procedure is also referred to as a VATS, or a video-assisted thoracoscopic surgery. This is to view the lymph nodes in that area. A medionoscopy is when a surgeon takes a sample of the lymph nodes in the center of the chest underneath the breastbone. You are probably asking why these tests would be performed instead of just taking the patient to surgery and removing the lung cancer and the lymph nodes. Well, it's been proven that if a patient has lymph nodes that are positive for lung cancer, they should receive neoadjuvant therapy prior to having a cancer-directed surgery performed. So it's very important to stage those lymph nodes prior to surgery. There are two main types of lung cancer: non-small cell lung cancer and small cell lung cancer. You will see them identified by these acronyms as listed on the slide. They are biologically and clinically very distinct from each other, and that's why they are staged when, I shouldn't say staged differently, when they figure out survival by stage or overall stage, they are separated. Okay, the survival is almost always, when you see it, you'll see the non-small cell lung cancer survival rates and small cell lung cancer survival rates, just because there's such a big difference between the two, because they are biologically and clinically very distinct from each other. The histology of a lung cancer is the most critical information that must be determined by the physician when a patient is diagnosed. The reason for this is the treatment varies significantly, as well as the prognosis between the two types of histology. Here are two photos. The left is a small cell carcinoma. That's what it looks like under the microscope. And the one on the right is one type of non-small cell lung cancer. The most common non-small cell lung cancer carcinoma includes adenocarcinoma, which there are many different types, and I've just listed just a few here on the slide. Then there's squamous cell carcinoma, large cell carcinoma, which includes giant cell and spindle cell carcinomas. There's adenosquamous cell carcinoma, and then less common non-small cell histologies include carcinoids, mesothelioma, and sarcomas. So when it comes to a cancer, the histology being called non-small cell carcinoma, that's a very NOS code. It's a very non-specific code because there are all different types of non-small cell carcinoma. Sometimes they can tell exactly what type of non-small cell carcinoma it is. Sometimes, depending if the specimen is too small, sometimes they can't tell exactly the type of non-small cell carcinoma they have. But just know that there are many different types of non-small cell carcinoma. Now, small cell carcinomas are pretty much just small cell carcinoma with a few variations, but usually just stated as small cell carcinoma. 10 to 15% of all lung cancers are small cell carcinoma. This is a very aggressive, rapidly growing cancer which tends to disseminate or have distant metastases at the time of diagnosis, which is why it has such a poor survival rate. Small cell is usually not treated surgically, but treated with chemotherapy. These tumors are more often centrally located near the mediastinum and the hilum. Small cell carcinoma may present with metastatic disease to the lymph nodes from what they call an occult primary. And what that means is that the primary lung tumor cannot be identified. It's not seen by imaging. You know, they do a CT scan, a PET scan. They can see that the lymph nodes are positive, but they don't see any primary tumor mass or nodule. So that's what they call an occult primary. These cancers are radiosensitive, but are not usually curable by radiation therapy. Pleural effusions are not as common in small cell carcinoma as they are in non-small cell carcinoma. So if a patient presents with a pleural effusion, a physician will believe that the patient has a non-small cell lung cancer until proven otherwise. Consideration that must be taken into account before surgery is performed include the histology type. Remember how we just said that small cell carcinomas usually aren't treated surgically, so that's why histology type is so important. Size of tumor, location of the tumor. Where is that tumor? Is it on the inside of the lung? Is it near the hilum? Is it on the very outside, the peripheral part of the lung, in the bronchi, things like that? Where is it located? If a complete tumor resection is achievable or not, and this may depend on the size as well as the location of the tumor. Okay, so it's very important to know, can we completely resect this tumor? If it can't be completely resected, well then there's no reason to go in there and remove the lung or that part of the lung. And then it's also important to know the patient's estimated post-operative pulmonary function status. It needs to be determined that the patient will still have good breathing function after surgery. Surgeons do not want to do more harm to the patient by making their quality of life worse after surgery. Types of surgery for lung cancer include a wedge resection where only the tumor is removed with a good margin around it. A lobectomy is where the entire lobe where the tumor is removed. So if the tumor is in the upper lobe, then the whole upper lobe of that lung would be removed. That's a lobectomy. A segmentectomy may be performed if the entire lobe cannot be removed. The surgeon will remove the portion of the lung where the cancer is. This is more than what would be considered a wedge resection. So it's between, a complete lobectomy, but it's more than what just a wedge resection is. Then there is a pneumonectomy, where the entire lung is removed. Obviously, the patient would have to have a really good pulmonary function status for this to be performed. If considering radiation therapy for lung cancer, one must keep in mind that the pulmonary function impairment after receiving radiation therapy is very similar to surgery. So not all patients can receive radiation therapy. Radiation therapy can be used as a primary treatment for early stage non-small cell lung cancer, those that are confined to the lung. if the patients are not surgical, if they are not a surgical candidate. Okay, so let's say a patient has an early non-small cell lung cancer, so only 1 centimeter, but for whatever reason, they can't go in there and do a wedge resection or any type of operative resection. That patient may be able to receive radiation to that lung nodule, and the lung nodule may disappear and the cancer may go away. But once again, also have to consider, can that patient, handle that radiation therapy? Radiation therapy can once again be used prior to surgery to reduce the size of the tumor if it is large, or to reduce the size if the tumor is invading other structures, so that the surgery may be performed with negative margins. Radiation is sometimes given after surgery to eliminate any cancer cells remaining, or if the surgeon ended up not getting negative margins, then they might have radiation after surgery. Radiation is also utilized to treat metastatic disease on metastatic sites such as bone and the brain. It can also be used for palliation of symptoms such as cough, pain, or shortness of breath. Chemotherapy is utilized to treat non-resectable tumors. So small cell carcinoma is highly sensitive to chemo, so those cases are treated with chemo and may also include radiation therapy as well. Chemotherapy does not cure a patient of their lung cancer. It may shrink it and stop it from growing, but it will not cure it. Chemotherapy can also be used prior to surgery to shrink the tumor with or without radiation before the patient is taken to surgery. Once again, this is called neoadjuvant therapy. Chemo can be used for patients that are found to have lymph node involvement or positive lymph nodes after receiving surgical resection. So if they do a surgical resection and the patient has positive lymph nodes, most likely that patient will be offered chemotherapy. And chemo is also used if a patient has distant metastatic disease or stage 4 disease, if they so choose. Then there is targeted and immunotherapy for non-small cell lung cancer. These treatments are not effective on small cell lung cancer, so they're only used for non-small cell cancer. Targeted therapy is a treatment that targets the cancer's specific genes, proteins, or growth factors. The different types of targeted therapy include anti-angiogenesis therapy, which focus on stopping angiogenesis, which is the process of making new blood vessels. Tumors need the nutrients delivered by blood vessels to grow and spread. So the goal of this treatment is to starve the tumor. I've listed 2 anti-angiogenesis drugs here. You do not need to memorize them or anything. It's just kind of like an FYI, and this is what 2 of them are. Then there is the targeted therapy of epidermal growth factor receptor inhibitors, or EGFR. Researchers have found that drugs that block the EGFR may be effective by stopping or slowing the growth of lung cancer. Once again, I've listed some of those specific drugs that are now used as EGFR inhibitors. As we have discussed before, immunotherapy is designed to boost the body's natural defense to fight the cancer. And there are 2 drugs here, the Opdivo and the Keytruda. Those are 2 immunotherapies that are now being offered for non-small cell lung cancer. There are only 2 site-specific data items collected by the cancer registrar for lung cancer. The first is separate tumor nodules in the ipsilateral lung, or the same lung as the primary tumor is located. So if there's the main tumor is in the right upper lobe, are there other separate tumor nodules in that same lobe or in a different lobe of the lung? We need to collect how many nodules there are in that same lung as the primary tumor is in. Then there's the visceral and parietal pleural invasion. This illustration demonstrates the different classifications of pleural invasion by the tumor. And we record the type of, or the class of that invasion for our data field. So once again, you don't need to memorize these. It's just to kind of learn about them and get to kind of know some of the things that you'll be seeing and reading about next semester when you abstract lung cases. As always, if you have any questions about this week's presentation, please contact me in the virtual office. I hope you learned and enjoyed learning more about the management of lung cancer. Hope you guys all have a great week. Take care.